the record, and then let me turn this over to you.
Those are the GPS coordinates Sergeant got from during the battle when she was killed.
You know what's interesting about these coordinates, Colonel?
They got smack in the middle of the battle, not took away to recon.
Hey, it should be all yours, Dr. Eschelbach.
Okay.
It's a divorce file.
All right. Can we see everybody? There we go.
Love the hat.
All right.
Filing a false report is a court martial.
All right. Greetings. I'm going to start with just a little bit of conversation. See if I can share my screen. And we'll get this going.
I'll do that. Thank you. And I won't leave out any of it.
There we go.
No, no, you trust or seduce my wife, or ruin my marriage or any of it. And his grief will confirm his statement witness to his memory.
All right, and
So both of you disagree with regards to Sergeant Goff.
okay, I think we're ready.
We both agree he should be recognized for his valor.
Yeah, but the medals are for the living.
And I think, Jane, you need to mute your...
If we award this medal to Sergeant Goff, his wife will
There you go.
Sorry, it popped back on whenever I switched.
Okay, fantastic. All right, I hope everybody can hear me. I can see folks on the left. I am going to ask you to do me a favor, and you figure out, I see a bunch of folks on the left. I want you to just, in your mind, number yourself 1, 2, 3, 4, 5, 6, whoever's online, because we're going to have a participation with this. So we're going to talk about EKG training and STEMI. And I'm going to refer to a book I'll hold up in front of me right here. And, well, it's backwards because it's the Dubin's book, Rapid Interpretation of EKGs. The reason that I refer to this book is if you don't have it, you should. And my slides tonight don't come out of that, but recently I had to retake my boards and I picked up that book just so I would be ready. So when we talk about EKG training and STEMIs, we're going to talk a little bit about basic EKG, and I'm going to assume that you're all at that level. Then we're going to talk about acute coronary syndrome. And then we're going to talk a little bit about ST wave elevation MI, which is the majority of this talk. And then for participation, I'm going to have you guys mute and unmute yourselves so you can talk to me one at a time. So if you can figure out on the side who's going to be 1, who's going to be 2, who's going to be 3 as I talk, that would be great, because I'm just going to call on the numbers. Okay? So here's our objectives. Number 1, we're going to review, I'll take my hat off. Good. We're going to review EKG basics and basic cardiac anatomy. We're going to review infarcts and ischemia. We're going to review regional changes, briefly discuss the next steps after a STEMI diagnosis. What we will not discuss is more subtle changes. So if you want to start talking about reading EKGs through bundle branch blocks, we're going to stay out of the weeds on that one because this is the basic. All right. So I say don't panic. When you're in medicine and you're an intern, that's the first year, you are the first to respond to a STEMI or a cardiac arrest. And rule number 1 of medicine is don't let them see you sweat and don't panic.
My first code. See, here's how it works. Someone's heart fails, they beat everyone. The first doctor in is to run the room, tell everyone what to do, basically decide if the patient lives or not. What, am I crazy? You chicken. Don't worry about the patient. Turk was already there, learning by doing. Plus, it turned out the guy was just sleeping, attached to a faulty monitor.
Okay. So, funny, yes. True, yes. I've seen it happen in my career where people were shocked. VTAC when they had a faulty monitor. At the same time, I've seen people run the other way. So this is a really basic question. Is your EKG normal or abnormal? How do you know what the difference is? And it's kind of like feeling around in the dark for something in your utility drawer. You know what a fork feels like, you know what a spoon feels like, and you decide which one is which. So by the time you read enough EKGs, eventually you know what normal is and you know what abnormal is. And so as we begin this, we're not going to go through all the aspects of EKG because I'm going to assume that you're up there already. If you want to have a basic discussion in the future about normal and abnormal EKGs or EKG 101, we can do that. But for now, I'm going to assume that everybody is normal and abnormal, knows what normal and abnormal is. And Jane, if you don't mind, if there's something that you can see, question that I don't get, you can unmute and ask me the question.
Absolutely, sir.
All right. So very quickly, let's talk briefly about a normal cycle. Here is a P wave. P wave starts up here in your sinoatrial node, and it's represented here by atrial depolarization. The QRS wave, this next segment in between the P and the QRS, is a very short segment where it reaches the AV node and it's waiting for the ventricle to depolarize. At this point, the signal goes from the sinoatrial node to the AV node, and it goes down these bundle branches where it goes to the left and right, that's backwards, the left and right ventricle. The bundle branches carry signals from the AV node and will tell the heart to contract. Electrically, the signal spreads out and you get your QRS complex. This T wave is the repolarization or the setting back to a zero charge of the ventricle. Two things that you're going to wonder is, if this P wave is atrial depolarization, where's the repolarization of the P wave? And the answer is it's hidden inside this QRS complex. We really don't see it. This T wave here is when the ventricle resets. What happens in the electrical cycle is one thing. What happens in the heart is another. As the atria depolarize, they send a signal to the atria and they contract. That's the top of the heart squeezes. The top of the heart squeezes and puts the blood into the bottom of the heart. You get your QRS complex. Then when the bottom of the heart contracts, it sends the blood either out here to the lungs to get fresh blood or out here, out the aorta, to go to the heart. And keep in mind that all this PQRST is an electrical signal. So any abnormalities to this signal is an electric signal, not what's going on in the heart, even though what happens in the heart will be reflected in the EKG. If I've confused you enough, I hope not, and we'll move forward. Let's talk a little bit about ischemia to infarct. Keep in mind that acute coronary syndrome is a continuum, meaning that you go from a normal state here to the state of infarction. The less blood you get, the closer to infarction you'll get. So once myocardial cells become deprived of oxygen, the electrical pattern for that area will change. So just like we said in our last slide here, as you get less blood supply, you're going to find a change in the QRS complex. How does that look way over here? Over here, you've got a coronary artery that's supplying blood to the heart. And as you get changes that go from ischemia to injury to infarct, you're going to get a change in the EKG. the blood comes into the heart and it's supposed to oxygenate the heart. Now, the heart is the only organ that actually not only supplies blood to the rest of the body, but it has its own blood supply. And that, of course, is what an MI is. And we'll go over that in a few minutes. There are these smaller veins that are called Thespian veins and diffusion veins. And these veins and arteries work together to keep the inside of the heart going. So what does it look like, ischemia to infarct? This is what we call a flipped T wave. If you remember back to our original picture, the T wave was upright, and it is most of the time, with the exception that we'll go over in a few minutes. But when you see this T wave flip, it usually means that the heart's not getting enough oxygen and you get a depressed ST segment. Flipped T waves are opposite of the normal direction, shows that you're not getting as much. That's ischemia. And remember, they happen in regional distributions. We'll talk about that in just a minute. So image is everything. This first one is a fireman's hat. Most of you are paramedics, but in a lot of my regions, especially here in Central Oregon and the more rural regions of the country, you're not only going to have to be a paramedic, you're going to have to be a fireman. So if you're in a large place like Seattle, you're one or the other. If you're in a smaller place like Central Oregon or more rural, you're going to be the other. So this is a fireman's hat, and I'm going to refer to that. The other image I'm going to talk about is something called the tombstone. Tombstone, you know what that looks like. It looks like this. Oops, sorry. That's the wrong tombstone, but that's a seasonal question. We'll talk about tombstones in a minute. All right, so here you can see a fireman's hat on the right in the lower area. If we look at it, this is what's called ST elevation. And ST elevation is the part of the STEMI we're talking about. ST elevation, MI or myocardial infarction, otherwise known as a heart attack. So the injury has the ST segment elevation with or without T wave changes. ST segments can be flat and elevated, and ST segments can be convex up. We're not going to get into the weeds with some of those convexities. But here, we've got a flipped T wave. We've got a fireman's hat that shows us ST elevation. We'll find out there are some subtle changes, and go back to the original picture I showed you of the fork and the spoon. Are you looking at a fork? Are you looking at a spoon? So we call a fork normal. This is a spoon. This is abnormal. Now in Dubin's, they're going to have you go by rate, rhythm, analysis, and hypertrophy and axis. I am not going to go there today because I'm going to assume you already know that. If you don't, we'll go back to basics at a future time. So what happens to the STT wave as you go from normal up here? Here's our fork, P, QRS, T. As we get more ischemia or less oxygen, our T waves begin to change subtly. And keep in mind, this is nothing but electric. This is an electric signal with what's going on to the heart. As you begin to get injury, you start to get those elevations of the ST segment, and it looks more and more like a fireman's hat until you get here and here, and you get to infarct, and the picture changes altogether. What are Q waves? Remember, you've got P. Q is the first downward deflection of any QRS complex. Q, R, S, and then T, right? Q waves are a late finding. And we'll talk a little bit about that in a minute, but briefly, Q waves are a late finding and they don't show up until later. Q waves are significant if they are greater than 1/3 of the height of the total QRS complex. So this is about right here, 1/3, and if you were to break this in, it's probably about 2/3. So they are significant there, but they usually don't show up until a day or so later. All right, this is the only slide you're going to see from me about cardiac anatomy where we talk about the arteries. Why? Because particularly I don't care. Why is that important? You're going to see on your boards, of course, or your questions, if you have one type of lesion, where do you think it might be? But I'm a caveman. I'm in the ER. I know what a STEMI looks like. I'm going to worry about this right coronary artery or this coronary vein or the left anterior descending. I'm going to leave that up to the cardiologist to worry about because I don't particularly care. Your boards might, your questions might, but particularly as a practicing physician, I don't. We do have infarct regions. This is important. I'm sure you all carry in your pocket one of those cheat sheets for regions of infarct. I'll show you a picture of what it looks like in a minute. But you've got septal regions, V1 and V2. Those are supplied by the left anterior descending, and that's on this thing here. Here's your left anterior descending artery. Okay, V3 and V4, they are also supplied by the left anterior descending here. Inferior leads supplied by the right coronary artery. Here's my right coronary artery. And lateral leads, V5, V6, 1 in AVL, supplied by the left anterior descending, and the circumflex. Here's your circumflex artery. So when a cardiologist takes a patient to the cath lab, he's going to be putting dye in the heart and looking to see where the clot is so he can either put a stent in here, meaning a bypass, or go in and retrieve the clot. If it's too big and it's too extensive, then he's going to call the cardiothoracic surgeon and they'll put in a bypass. That's another discussion for another day, but they take a vein or artery out of your leg and they bypass this to get to the area that is diseased, get past the area that's diseased, and into the fresh area. All right, posterior, it's not shown on a 12-lead EKG, but don't forget about it. It's supplied by the right coronary artery. We'll talk about them. They're usually a big R wave with ST depression, upright T waves, and we'll come back to those. And remember about your upside down mirror image, and I'll show you what that means when we go over some particular EKGs. Here are your infarct regions. Your infarct regions are, yes? Okay. These are the infarct regions that you're going to have, and there, you'll see that each one of these is a particular region on the EKG. This is called a 12-lead EKG, 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12. So as we look at changes in the EKG, meaning we see the difference between a fork and a spoon, is it normal or abnormal? And then we look at the EKG and say, all right, where is it abnormal if it's normal, if it's abnormal, or where is it normal? Then what we're going to do is look at each of these regions. So as I ask you questions, I'm going to say, first off, normal or abnormal. Then I'm going to ask you to say where. I might ask you to say fast or slow. And we're not going to get into rates and rhythms and all that because that's another discussion. But as I do ask you questions, you're going to try and bunch things together. 2, 3, and AVF always go together. I like to start with them and look at them and say, am I looking at a normal EKG in that region or an abnormal? Keep in mind that lateral, 1, AVL, because it's there, and V5 and V6 are also lateral. Your septal region here is V1 and V2. Your anterior is here. What does that mean? I'm going to go back very quickly to this picture and tell you which part of the heart. You've got the inferior part of the heart. You've got the lateral part of the heart. And you've got the posterior part of the heart, which we can't see right now. Look at this question and see this. AVR is kind of empty right here. It's empty because it doesn't tell us a whole lot, but we will see what that means in a few minutes. So the R is usually right, the L is usually lateral, and the F stands for inferior. Reciprocal changes happen in 2 regions of the heart. That means that the inferior aspect, 2, 3, and AVF, will usually have changes that are reciprocal in our lateral leads. 1, AVL, V5, and V6. What does he mean by that? So if we have ST elevation in our inferior leads, here, here, and here, we'll usually have some type of ST depression in our lateral leads. Or if we have ST elevation in our lateral leads, lateral, high lateral, V5 and V6, we'll probably have some form of ST depression in our inferior leads. So only lateral and inferior lead regions have reciprocal changes. Anterior infarcts may not be accompanied by reciprocal changes in other areas of the EKG. We may only have those areas there. Sorry, here and here. Septal infarcts may not be accompanied by reciprocal changes in other areas of the heart. So our septal is 1 and 2. Anterior is 3 and 4. Okay, what are things that are not a STEMI? These are what I'm going to call the foolers. What are the things that might look like a STEMI but aren't a STEMI? Let's go back to our discussion about the fireman's hat. A lot of times you can look at these and they all look like fireman's hat or tombstones, they're also called. Sometimes when you look at an EKG and it doesn't make sense, meaning you go back to your regions here and you go, wait a minute, this person's having a heart attack in their inferior leads, they're having an attack in their lateral leads, it looks like they're having a heart attack in their septal leads and anterior leads. So can you have a heart attack in every single vessel at once? It could be possible, but most likely not. So when you see ST or PR depression with diffuse ST elevation MI looking EKGs and it's all over the EKG, it's more than likely a condition called pericarditis. Because remember, the heart is covered with a very thin covering called the pericardia. And if that's inflamed, it's going to give an electrical, this is nothing but electric, remember, it's going to give you an electrical belief as you look at the EKG that you're seeing a heart attack all over the place. Bundle branch blocks, like left bundle branch and right bundle branch, have their own looks as well. Early depolarization, like young healthy heart, can happen in a couple of different ways. This is the depolarization aspect here. And if you have early depolarization or pericarditis or some type of strain, you can get some changes that look or begin to look like an MI. And sometimes we have T waves that don't match each other, and these leads are usually less than 1 millimeter. We'll talk about that in a minute. All right, what are the changes that are pathognomonic or an MI? So when the ST elevation is 1 millimeter or more with a flat ST segment right here, the best way to do that is you take a ruler, put it underneath, and watch that line right there. And if it goes up at least 1 millimeter, and it's at least a couple of different EKG patterns in a row, like V1, V2, V3, with a flat ST segment, we start worrying about it. Elevated ST segment of 1 millimeter more with a convex ST segment. So here you go, P, Q, R, S, T, convex. It's starting to look like a fireman's hat. Here's your typical fireman's hat, which is ST elevation. And then reciprocal changes we'll also talk about. These are something you can study on your own, and they'll take time. If I were to ask each one of you to put your hand in a drawer and identify the fork or the spoon, you could easily do that. EKGs are the same. If you look at them enough and look at enough of them, you'll start to see these changes. The regional distribution we talked about already. And history is consistent. Have to keep in mind that sometimes, every once in a while, you'll do an EKG and person is not having any chest pain at all, and they've got these weird changes that look like an MI. And you try and get the history, because sometimes people just want to fool you. And very often, people who have, let's say, people have some chest pain who just a week ago had brand new stents placed in their heart. They had an MI, they had stents placed. Sometimes it takes a long time for that EKG to return to normal, and you can get fooled. When does that become important? It becomes important when you are in the field and you're determining whether or not to wake up the cardiologist at 3 o'clock in the morning to call in the catheterization team, which is something we do in our region. My paramedics in our region, we've taught them good enough that they do what's called a Heart 1, and they can actually activate the cath team without anybody else by calling that ahead of time. So in 2015, the American Heart Association refined some of the changes, and they want you to do a few things. They want you to consider the interpretation of an acute MI. What I mean about that is when you get a piece of paper that's a 12 lead, very often it's going to say normal, or it's going to tell you acute MI. Sometimes paramedics see the word acute MI, they kind of panic a little bit because they're not seeing where the changes are, and they'll activate a Heart 1 or activate the hospital and let them know what's going on. What I want you to do is to consider the interpretation, and as you look at the EKG, decide, what do I see that convinces me that this is an acute MI? Whether it's the patient's presentation, their history, and if I do see it, how can I prove it and disprove it? And you have to play your own devil's advocate. Here is a difference, the only change that's happened in the last several years since EKGs were invented. We finally figured out that women with 1.5 millimeter ST elevation in V2 and V3, or men with 2 millimeters of ST elevation V2, V3, can present as an MI. Why is that important? Because women have atypical signs, and women make it harder for us to determine if an acute coronary syndrome is happening. What do I mean by harder? Typically, we had this rule. If you had V2 or V3 with 2 millimeters of ST elevation, it was an MI. If they were 1.5 millimeters, they fell out. But what we did to change that is realize that because women don't have classic symptoms, and sometimes their EKGs are slightly different, we changed that rule to 1.5 millimeters. The second refinement, which is not new, is 1 millimeter of ST elevation in 2 or more contiguous leads. Contiguous leads means 1, 2, 3, 4, 5, 6, V1, V2, V3. So if 1 millimeter ST elevation in V1 and V2, or V2 and V3, or V4 and V5, if 2 of them are together and there's 1 millimeter together, that's enough to call an MI. And then this is our rule out of our protocol. A local emergency department calls a STEMI based on a 12-lead EKG if available. In some of our regions, we're able, some of our machines can talk to the fax machine in the emergency department, and you pick up the phone on the HEAR radio system and you say, we just faxed you an EKG. Will you please take a look at it? We're not sure. Or sometimes those go over the airway and they are spit out to an email, and the nursing supervisor can check her email, and that email has the right lead, has the right interpretation, and it can be reviewed by a physician. The difference is in some areas like Central Oregon, where we have trees and mountains and valleys, or any region that you might be, it's not always easy to get that EKG transmitted. Okay, acute myocardial infarction. Not all acute MIs are STEMIs. I'll tell you what that means in a minute. STEMIs, or ST elevation myocardial infarctions, are acute MIs that are treated differently by transporting directly to a STEMI receiving hospital. What we have in our region and what the American Heart Association has encouraged us to do is bypass smaller emergency departments that don't have a cardiologist there in the receiving hospital so that you can get that person to the cath lab as soon as possible. Now keep in mind that you might be in the middle of Wyoming and the only place to go is your ER that's 50 miles away, or you might have a choice 60 miles away the opposite direction. In that case, you might use a helicopter to get to the patient to the 60-mile away rather than the closest facility. Here in Central Oregon, we're about the size of the large state of maybe Connecticut. And we've got 4 hospitals. 3 of those 4 hospitals don't have a cardiologist in them. So we have everybody bypass the smaller hospitals and go directly to the hospital where a cardiologist can take them to the cath lab. All chest pain patients are treated as an emergency, and they might be an acute myocardial infarction. And chest pain has the potential to be a non-STEMI, and they go to the closest facility for further evaluation. So what's the difference between a STEMI and a non-STEMI? A STEMI is everything we talked about. ST elevation MI. Time is muscle, and they need to get to the cath lab as soon as possible. A non-STEMI is somebody who has an EKG that's normal or does not show a STEMI. They might be having chest pain, and they're going to need some blood work, and they're going to need x-rays, stuff that you can't do in the field. They might actually be having a heart attack, but there's no way to figure that out from an EKG alone. So those people can go directly to the closest facility, and then later, if I determine in the emergency department they're having a heart attack, I can send them out by helicopter or another ground. Acute coronary syndromes. Okay, here's where we talk in our British accent, and we can watch a little video. It's sudden ischemic disorders of the heart. It includes unstable angina and acute myocardial infarction, and it represents a continuum of a similar disease process. Remember, we talked about how EKGs go from normal to ischemia to infarction. Well, acute coronary syndrome is that process. It's a disease process that's moving towards a heart attack. So it could be simple as someone who has chest pain, you give them an aspirin and a nitroglycerin, and then they move on forward. Do I have a question? Okay. Let's watch this vignette.
Acute coronary syndrome, or ACS, is the leading cause of death globally. The spectrum of ACS ranges from unstable angina to non-ST segment elevation myocardial infarction and ST segment elevation myocardial infarction. Ultimately, ACS is the result of an obstruction of the coronary arteries induced by an atherosclerotic plaque. ACS events are triggered by the plaque rupturing. This exposes subendothelial matrix proteins and other molecules. Platelets are recruited to the site, adhere to the injury, and, together with red blood cells and fibrin, begin to form an arterial platelet-rich clot. This narrows and eventually obstructs the coronary artery. The extent and the location of the blockage and the resulting myocardial damage determine the extent and the severity of the myocardial infarction. Life-threatening arterial clots are formed through two pathways: activation of platelets and generation of thrombin by coagulation factors. Targeting both pathways has been shown to be a viable therapeutic approach.
Okay, sponsored by Bayer Aspirin. There you go. Okay, so very quickly, that vignette showed, or that little video showed exactly what we're talking about. Initiating events are plaque rupture, a thrombus formation or a clot, and vasoconstriction, which the video did not talk about. So here on the left is a stable, normal lumen. A lumen is the hole through which blood goes. This fibrous cap and this lipid are what your doctor worries about if you have high cholesterol. We know that if you take a normal artery, people who don't have any signs or symptoms of heart disease, and you were to cut it open, we would find this lipid core based on how much cholesterol or family history that you might have. When this lipid core gets dangerously close to the lumen, you can see that the difference here and the difference here is significant. When this fibrous cap, the cap that sits over the little bit of cholesterol, gets ruptured, that's when acute coronary syndrome happens.
Woohoo! Look at that blubber fly!
So there's a little bit for Homer. Homer eats a burger, and a little bit of that fibrous cap gets pulled away from the cholesterol. And once the blood senses that that lipid core is exposed, it's almost like piranhas after a meal in the river. So a platelet comes, adheres to the side, and before you know it, one platelet calls his friends, and they have another friend, and they have another friend. Kind of like when you were back in high school, and you heard that one person had a party, and the next thing you knew, the house was full of your friends. More and more friends are called, and you get these platelets to stick together. They get big, and this area gets smaller and smaller. As the area gets smaller and smaller, keep in mind that less blood flow is going through here, so you're going to start to begin chest pain. those friends, the platelets, call in their friends fibrin, because this is like a blood clot. So if you nick yourself while shaving and you start to bleed, you put a little bit of tissue paper on it to stop the bleeding. You can think of the tissue paper as fibrin, and before you know it, you have a blood clot. And when you get a blood clot and there's no blood getting through, that's a heart attack. Then you get vasoconstriction because your body panics and it tries to decrease the size of this lumen. So here you've got some chest pain. Here you've got a bunch of platelets that are adhering, and your body says, how can I fix this? The only way your body can clear this out is to increase the pressure. It increases the pressure by making itself arteries smaller. And when the arteries get smaller, the pressure inside the vessel goes up, just like a hose, right? So if you're trying to get more water out of the hose, what do? You open up the valve and you let more pressure out. Unfortunately, the heart can't blow that clot away. And when it does, you wind up with a heart attack. So this is the cascade. You get plaque rupture, myocardial oxygen demand goes up, coronary vasoconstriction, you get the blood clot formed. What collateral circulation is, are there other areas of the heart that might be able to service the area that's getting sick? And if you don't have that, you lead to tissue death. When the tissue dies, the electric can't go through it. And when the electric can't go through it, then you get your EKG changes. So remember, like we said at the very beginning, the EKG changes are just a reflection of what's going on in the heart. Okay, this is where I'm going to ask you to assign yourself a number. Does everybody have a number? All right. I'm going to ask for number 1 to turn on your microphone and get ready. Can you identify yourself?
Number 1 doesn't have a mic, but he's on the chat.
Okay. All right. Very good. That's fine. If you don't have a number, somebody then read me his interpretation, because I can't see his interpretation, unfortunately. Let's see. All right. Maybe I can try and see. All right. We've got 10 participants. Number 1, what do you see here? First, let's say, is a fork or a spoon? Is it normal or abnormal? Does it look pretty good? Let's go over this very quickly. Here's a P, QRS, and there's a T. Here's 2, 3, and AVF. We've got an upside down T wave here. Dr. Eschelbach said that upside down means ischemia, right? But not always. And then V1, V2, V3. So somebody tell me what number 1 is saying, because I can't see it.
He says he's calling it a normal sinus rhythm, a normal EKG.
Whoa, excellent. Good. Normal EKG. Let's see why. P wave, QRS, T. Keep in mind that in AVR and in V1, your T waves are normally upside down. We look at 2, 3, and AVF. We don't see any funky fireman's hats. We don't see any tombstones. So 2, 3, AVF, inferior. 1, L, and then our lateral leads here, V5 and V6, they look okay. V1, V2 looks okay. That's our septal region, and our anterior region looks pretty good. So number 1, you get a prize, normal EKG. Number 2, sign on. First, normal or abnormal?
2 is Wayne.
Okay, can you hear me?
I can hear.
Yeah.
All right.
So normal or abnormal?
Looks like there's a elevation in V1, 2, and 3.
Okay, so I'm going to ask again, normal or abnormal?
Oh, I'm sorry. Abnormal.
Very good. Now let's look and see where it's abnormal. So you're saying V1, V2, and V3 looks weird, right?
Right.
All right. Anything else?
It looks like V4 is a little.
Looks a little up, right? Good. So what region is this one here, V1, V2?
Anterior.
Okay. This is actually V1 and V2 is septal, but that's okay. Anterior is 3 and 4. Remember, it goes septal, okay, anterior, lateral. So we've got anterior and septal changes. Now, let's look over here. 2 and 3, are there any real big changes? Not really, but I see a little slurring here. Just a little slurring. It's nothing specific. So if I see septal and anterior changes, what kind of MI would you want to call this?
Septal MI.
All right. It's, well, you're close. It's anterior septal. All right. The reason because we've got, and this is just nomenclature. No one says septal anterior MI. Cardiologists call it anterior septal MI. That's okay. But we saw the tombstones, right? We saw the tombstones. We saw the fireman's hat right here. So this is a good example. This is your fireman's hat. These are your tombstones. And you made the correct diagnosis when you said anterior septal MI. Great job. Let's go to number 3.
3 is Drew.
Yes, hello.
Hello, Drew. So
Hi.
let's say fork or spoon, normal, abnormal.
This is abnormal.
Good. All right, we got abnormal. Let's look and see where it's abnormal. Let's start here. Normal or abnormal?
Abnormal.
Good. So we've got a lateral lead that's abnormal. Then we're going to drift down here to the other lateral leads. Abnormal or normal?
That's abnormal as well.
Good. All right. Now, 2, 3 in AVF, do they look normal or abnormal?
They look abnormal.
Okay, but they're not elevated, so we'll keep that in mind that the inferior aspect looks weird.
It's lacking, so it'd be in the transition of ischemia.
Mm-hmm.
Is it polarizing? It's
Could
position
be.
down.
So we've got 1, 2, and then let's look over here at our other lateral leads, V5 and V6. So, normal or abnormal?
Abnormal.
Okay, so if 1, L, and V5 and V6 are abnormal, that's why we can get these reciprocal changes in 2, 3, and AVF. Now let's look here. Here's our septal region. Normal or abnormal? Right here at V1.
Normal.
It looks normal. Good. And then keep in mind that, remember, these guys share the same blood supply, and this starts to look abnormal as well, right?
Yes.
So we've got anterior changes here, here, and here. We've got lateral changes here, 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 and here. So what do you want to call this?
That would be a
You think it's a STEMI?
yes.
It's a STEMI. Okay, that's good. It's called an anterolateral MI, and you picked out every one of the abnormals. Keep in mind, your job Your job as a paramedic is not so much to remember this, because that will come with time. Anterolateral MI will come in time, and you'll remember a capital L there because you have the there. You'll figure out that it's a fork and a spoon pretty early. All right.
Okay.
Excellent. Good job, Drew. Number 4. Who's number 4?
That's me. It's Will Schaefer.
All right, Will. I'm going to cheat and tell you that the machine is calling this an acute MI. So let's look at it and go, why? Now, first off, we'll look and go normal, abnormal.
I'm going to say normal.
Okay. It does say normal. It has a lot of normals, but let's look why it might be abnormal. Let's look at 1 and AVL. Okay. Are they a little bit up? Do you think they're at least a box up, maybe?
Yes.
All right. So this little area here and this little area here is slightly elevated. 1, AVL, and then let's go over here. Is this T wave in the right position? Is it up or down?
Down.
It's down, but it's supposed to be up. Okay. So normal or abnormal?
I'm
You can
guessing
change.
because of the elevation and the inverted, it's going to be abnormal.
Abnormal is good. So let's go back again. Why do I say is the machine smarter? Your machine says MI. Now I got to figure out, wait a minute, I don't see it. Then I'm going to look at 2, 3, and AVF, and they don't look too bad. But something bothers me about this ST depression here, just a little bit. It's a little bit. Now I look at my T waves here, and I'm starting to say, well, that looks okay, but it's upside down here, and it's supposed to be upright. Now I'm going to tell you that this person is 60 years old. They're diaphoretic, they're pointing to their chest, and they were shoveling snow. So, do you wake up the cardiologist or not?
I would say probably not.
Oh, okay. All right. You can wake them up because it's a really early MI. So
Okay.
what's going to happen is you don't wake the cardiologist up. That's fine. That's okay because you don't see a STEMI here, but you see some concerning changes. So you
Yes.
give them some aspirin, you give them some nitroglycerin, and you start rushing to the hospital, and all of a sudden his chest pain gets worse. You repeat the EKG, and all of a sudden you get big ST elevations. So it was kind of a trick question, but you were good at picking out all the subtleties. You knew that this didn't look right, and this didn't look right, and these were upside down. The machine was smarter than us because it said, something's going on. There's diffuse T-wave inversion here and here and here. And this looks a little bit slurry. And this is an early high lateral MI. What happens is in about 5 minutes on your way to the hospital, this guy's going to get worse chest pain. And you're going to repeat the EKG, and it's going to look like a STEMI. So it's kind of a trick question, but you did well. All right. Number 5.
Rochelle, you're up.
I'm here.
All right, Michelle, normal, abnormal?
I would say abnormal.
Good, we got it. All right, so if it's abnormal, let's look and see why. Here's one region, okay? Here's a lateral. Does this look normal or?
Looks like it dips awfully low before coming
Yeah,
back up.
so when I see an upside down or a slurring segment in a lateral lead here and here, I start to think, what do these belong to? 1 and AVL. What do they go, what region of the heart?
That's the lateral view.
Lateral, good. Let's look at her other lateral leads, V5, V6. They look pretty normal to me. They don't impress me. But what do I know about reciprocal changes? Reciprocal changes in the lateral region are going to affect the inferior aspect. So let's look at inferior. What are our numbers for inferior?
The inferior is 2, 3, and AVF.
Good. Let's look at 2, 3, and AVF. Here's 2, here's 3, and here's AVF. What's that look like to you?
It's a definite elevation.
Yeah, it's at least how many boxes? 1, 2, 3, 4, 5, 6 here, maybe close to 2 here, and maybe 1, 2, 3, 4 here. So, are you going to wake up the cardiologist if this patient has got diaphoresis and a history of smoking and diabetes, maybe?
Yes.
Wake them up. All right, acute inferior MI. Good job. All right, number 6.
Dang, it's your turn. Dang Tran, where are you? He's typing. He doesn't have a microphone.
Okay, that's fine. So let's look at normal, abnormal.
He says abnormal.
Okay, so acute inferior MI. All right, sorry, this is where I hit the wrong button there. Abnormal. Where do you think it's abnormal? Let's look at 1, AVL, and V5, V6. So normal, abnormal.
He says abnormal, and then he said lateral MI.
Yep, okay. 1, AVL, V5, V6. Okay, now let's look a little bit. We know that they have lateral goes together. Do we see any changes, reciprocal changes in the inferior? Actually, I see what looks to me like some elevation here and here and here. So it's possible that we could have an inferior MI and a lateral MI. So he called lateral MI, and I call this an inferior lateral MI because, wait a minute, Dr. Eschelbach, you said if I have lateral changes, I'm going to have reciprocal changes in the inferior. But this is one of the places where inferior and lateral can go together. 2, 3, and AVF. So your machine said,
Dang did note the reciprocal in V1 and V2.
Very good. And V1 and V2 is reciprocal changes. So there you go. V1 and V2 are abnormal. So there you go. Good job. All right. Next one up. Do we have?
I have a quick question about the last one.
Yes, sir. I'm going to go back.
Yes, on that one, where you got elevation in V4, does that lead you to look into the anterior aspect of it? Where since V3 and V4 are anterior?
Yeah, and there, right there and there, you mean V3 and V4 here? V3 looks pretty normal to me. V4 is starting to look a little bit off of baseline, but it's only 1. And keep in mind that it's really up to the cardiologist to determine which vessels are not infected, but affected. So the answer is yes, but remember it's a continuum that some of these vessels share the same circulation, so you might see changes in that area.
Okay.
But that's a good pickup. I'll give you that. And it's really, my question is, are you going to wake the guy up in the middle of the night or not? Because he's not going to yell at you because you'll be drop the patient off. He'll yell at me the next day.
Right.
Okay, very good. Number 7.
John, it's your turn.
Do we have microphone or no?
Jonathan? Jonathan, are you, he said no microphone. He's here. He's on the typing. I forgot.
Okay, good. All right, Jonathan. This is a subtle one. Normal or abnormal?
He says abnormal.
Okay. Then we're going to go, what do we see? Let's go to our regions. Here's lateral. Is this normal or abnormal? You can say negative for abnormal or a plus for a normal.
Oh, he's saying abnormal, and he says he wants a 15 lead.
Okay, great. Well, that's very good, and I know why he said a 15 lead, but don't get ahead of yourself. I know why you want a 15 lead, but I'll walk you through this. Here's a little ST depression. 1, here's ST depression in an AVL, and then I'm going to go to my other guys here, and that's why he's kind of asking for maybe a 15 lead. But we've got ST depression here and here and here. Let's look at so we've got lateral covered. Now we've got inferior, 2, 3 in AVF. If I say abnormal or normal?
He says abnormal.
Okay, so we've got inferior depression here, 2, 3 in AVF. All right, so now we've got some lateral changes. We've got inferior changes. Now let's look at V1 and V2. V1, believe it or not, looks pretty normal to me. And V2 starts to show a little bit of ST depression. Now in V3 and V4, we've got some ST depression. So I've got kind of global, meaning all over the place, ST depression. Is this early pericarditis, or is it an early heart attack? It's probably not an early heart attack because we've got it everywhere. So maybe a little bit of nitroglycerin in this guy might change. And the answer is ST depression all over the place. Why did he ask for, somebody turn on and say, why did he ask for a 15 lead? What do you see that makes you think about a 15 lead? He's looking at these big depressions here and here. He's getting a little ahead of the game, but it was good because if we do a flip test, which we'll talk about in a couple of minutes, maybe this is a posterior MI. But because there's ischemia all over, I'm not quite sure and ready, I want to call a STEMI. I want to give some nitroglycerin and see how the EKG changes. Okay? All right.
Dang Tran had jumped in there and said possible posterior. Good job, Dang.
Yep, good. All right, now do we have a number 8, or are we back to 1?
Well, I have Jesse Sola. Jesse, now
Yeah,
Jesse, I know you're in P1. Do you want to try one of these, or do you want us to skip on to Adrian?
I could try one.
Okay, good.
Okay.
All right, Jesse, normal or abnormal?
Abnormal.
Okay, good. Where do we see abnormal? Let's start with 1, AVL, V5, V6. Do you see anything there? And there's a little bit of wandering baseline. Don't worry about that. 1 looks, lead 1 doesn't look too bad, does it?
No.
Maybe here a little bit. Who knows?
Yeah.
AVL, does that look abnormal or normal?
Abnormal, there's some depression.
Very good. Let's look over here at V5 and V6. Are you impressed by anything over here?
That looks ST elevation is high. Yeah, it's abnormal.
Okay. I'm going to say just a little bit, I'm going to be the devil's advocate there and say, I'm not too impressed. I can see what you're talking about is maybe that's off the ground a little bit, but I'm going to keep that in my back pocket because I know lateral is weird. And then, but is it ST elevation in 1 and L or depression?
Just depression on AVL.
Okay, good. So I know something's going on in my lateral leads. If I see something going on lateral leads, where do I look next?
Interior, maybe?
Inferior is perfect. 2, 3, and AVF. Normal or abnormal?
Abnormal.
Good, because if I draw a line right across here, that looks like it. What does this one look like to me or to you?
Fireman's helmet.
Yeah, fireman's helmet. And how about this one here?
Fireman's helmet.
All right, so I've got a ST elevation in my inferior leads with some reciprocal changes in my lateral leads. Let me look at V1 and V2 just to make sure. That looks a little funky right there, but it doesn't look all together. It doesn't look too bad, V1 through V6. Recognizing that those two together look a little bit weird. So what do you want to call this? Is it a STEMI?
Yeah.
It's a STEMI. And the answer is it's a STEMI. ST elevation, inferior MI. ST elevation in leads 2, 3, and AVF with reciprocal changes in my lateral leads. I'm going to call it an MI. Very good.
That is excellent, Jesse. Dr. Eschelbach, Jesse is still at P1, which means he hasn't even come close to starting cardiology yet.
All right, good job. Good job. You learned it all here tonight. Good job. Okay, our next victim.
Hey, Adrian, are you still here? Because I can't see you on the box list at the top, but I know you typed in earlier. Let's see if Adrian is still here, because Adrian Ramos was here. If not, then we're back to number 1.
Okay. We're almost towards the end, guys, so that's okay.
Well, I don't see Adrian, so we're back to Jeffrey.
All right. All right, number 2. All right, Jeffrey, you on?
Yeah. He is typing. He said that one's abnormal.
Okay, good. Abnormally.
He also says it's a septal ST elevation MI.
Okay. You got fooled, Jeff. All right, and I'll tell you why. Here's the fireman's hat, right? Here's a fireman's hat. So that's why he's calling septal MI. But look at our QRS complexes here and here. Are they normal or abnormal? They're a little bit wide, aren't they? This is the one, and what do you see right there? You remember rabbit ears? Anybody remember what rabbit ears are?
Yeah, some of them are starting to call left bundle branch block now, including
there you go. There you go.
Self.
So this is where you get fooled, and it's okay. It's okay to get fooled because this is a left bundle branch block. And it's a left bundle branch block because the biggest changes are on the left side of the heart. If you look at it and you see this and your eyes go right to it and you go, oh my gosh, there's a fireman's hat. That gotta be weird. And then you start to piece it together and go, wait a minute, okay, why is it weird? And you go back to the beginning. 1, AVL, lateral leads. Okay, but wait a minute, they look a little wide. Something else is going on. So remember, this is the one that you can get fooled by, bundle branch block. And it happens all the time. In my region, we have about a 95% to 97% positive STEMI Heart 1 in the field rate. our paramedics are wrong 3% of the time. Most of the time, it's because of bundle branch blocks. So,
Dr. Eschelbach,
yes.
Dang Tran asks, why is there ST elevation in V1 and V2? He's not understanding.
Why? Because it's when the QRS, there's your reason right here. And that's a really good question. Diagnosing an acute MI in patients with left bundle branch is so fraught with peril that the safest course is never try to make an EKG diagnosis of acute AMI in patients with left bundle branch block. That was written by Dr. Foster in 1982. All right, so I forgot to tell you to look at the QRS duration. I did that on purpose. And the reason being is if you look at this, when you've got a bundle branch block, think electrically inside the heart. I'm going to pretend that there's a picture. I had a chalkboard, but let's say this is our sinoatrial node here. It goes down to our AV node here, and then it breaks down into the left and to the right bundle branch. And that's what happens if the electricity is off just a little bit. The QRS complex widens and it becomes very hard. Now, there are criteria. If you remember under my objectives, the very first thing or the number 5th thing I said is we're not going to talk about subtle changes and get into the weeds. But I kind of lied because I wanted you to see this and know where you guys get caught. So go back to your Dubins and look at your bundle branch blocks. Okay. Next victim.
See, I believe that would be Wayne again.
All right, Wayne, can you log on?
I'm here.
Good. All right, Wayne. Normal or abnormal?
Abnormal.
Good. All right. Now I'm going to say, where is it abnormal?
Everywhere.
Everywhere. Okay. It's abnormal everywhere. Is the QRS skinny or wide?
Wide.
Okay. So if it's abnormal everywhere and we see a wide QRS and these things here that look like firemen's hats, they look like them kind of, sort of, these look like the tombstones, but our QRS is wide. What do you think is going on?
Another bundle branch block.
Yes, you're right. Good. All right. So we're getting the hang of it. We only have about a few more to go. Good job. All right, next victim.
Drew, you're up again.
Yes.
All right. Drew, is it right?
Yes, sir.
All right. Normal or abnormal?
Normal?
You think it looks like all the others we looked at?
No.
Okay. All right.
I see, and leads to, there's depression.
Okay. I see that right here. Good.
Yes. And 3.
All right, 3. But it's kind of upside down. It's weird. But what do you think? And this is, remember, I told you, again, Dr. Eschelbach lied. He told you to forget all the Rubin things, rate, rhythm, axis. Well, let's look at that rate. Is it fast or slow?
Slow.
All right, it's slow. Where in here do you see P waves? Let's see. Let's find one. Is this a P wave?
Yes.
Okay. I see a P wave there, but look at how long it takes for something to respond.
Yes.
So this looks kind of like a fireman's hat here. It looks a little weird, but from here to here is an awful long time, and it's a slow rate. And all of these look pretty wide. What are you thinking? Anything come to mind? If I told you it's not a STEMI, but the guy's got chest pain. Why do you think he's got chest pain?
That was a block somewhere.
Yeah. What type of block? That's okay. Is it? I'll tell you a story about my internship. We had a guy called Chuck, and Chuck showed up on Monday 5 minutes late. On Friday, he was half an hour late. He got the name Winky Bach, which is a second degree AB block. But this looks like a complete block. What's happening in the heart is the P wave, the heart's going, hey, beat. And the heart doesn't listen. And so finally, the ventricle fires on its own. So the answer is it's a third degree heart block. Sometimes it's associated with a left bundle branch block, but it's more probably a ventricular escape rhythm. What that means is the atria goes and it depolarizes, and then you wait. The EKG machine would have told you third degree heart block because it would have said, here's a QRS, I mean, here's a P wave, and there's no QRS. Where the heck did it go? What I want you to do, though, is your eye was trained to look at this and think of STEMI because this is a STEMI lecture. But then you got to go back to your basics. So this was a trick question, and that's okay.
So in lead one, is that so? The first.
This one here.
Yes. Is that the P wave right there, and then
that's a P wave, and it's some kind of funky who knows what, and then
it goes into T.
Yeah.
Okay.
That's weird. So
Okay.
your eyes went to this and said, oh, well, that looks like ST depression in my lateral lead. But what it is, it's just a big wide. Keep in mind that because it's a ventricular escape rhythm, because the ventricle is not hearing anything from the P wave, it just beats on its own. And that's what heart block is. In this area right here, there's atrial depolarization. In this area right here from the sinoatrial node somewhere into the ventricle, there's a loss of communication. Somebody cut the phone line. So the ventricle says, hell, I'm not waiting for my buddy. I'm just going to fire or else this guy's going to die. And that's what a bundle branch block is. So that's a trick question, but that's okay. All right. Here's the next one.
Will, I think it's your turn.
Alrighty.
Will, normal or abnormal?
I would say abnormal.
Good. Let's say where. Let's look at our regions. 1, AVL, and V5 and V6.
Those all look normal.
They do.
Maybe a little depression in one.
A little bit of slurring here and here. That little slurring right there, it's not specific. So then we'll go to our next one, and we'll go to 2, 3, and AVF. Do we see?
2, yeah, 2 has depression, it looks like.
Right. But is there elevation there? I don't see any. Good. 3 and AVF. I don't see anything. Good.
They look good.
All right. Now let's go to V1. Normal or abnormal?
Abnormal, you have elevation in both.
Right. This here is a classic tombstone right here. And then we've got a tombstone in 1 and 2. And we have a tombstone here in V3. And we have a fireman's hat here. So what are my regions?
Anterior, inferior.
Here's inferior, 2, 3 AVF.
Oh, no, sorry.
Septal.
Anterior and septal.
Good. So are you going to call a STEMI if this guy was out digging a hole and he's smoking and he's got diabetes? You're going to wake the guy up?
Yes.
All right. You win. Good guy. You win. Prize. Anteroseptal MI. All right. Be careful. This guy might have rhythm changes. This is the guy with an anteroseptal MI can all of a sudden go into VFib on you, go into VTAC. All right. Next victim.
Rochelle, I think it's you again.
All right, I'm back.
All right, Rochelle, here we go. Now I'm gonna tell you that this is, well, I'm not gonna tell you anything. Tell me, normal or abnormal?
I liked it better when you were telling me.
All right. Okay. How about normal or abnormal?
I'm going to go with abnormal.
Good. All right. It's abnormal. And if I told you that you have to look really hard at this EKG, what might you see?
Okay, so it looks like everything's just a little bit wonky.
Yeah, a little bit wonky. That's good. That's a good, you know, that's the word I would use. Wonky is a good word. So when Dr. Eschelbach told you that if things look wonky all over the place, you're a little bit worried, right? Let's look really close here, and I'm going to ask you to say, what do you see? Anything? Do they look kind of like maybe they could be bundle branch blocks, maybe a little bit like bundle branch blocks? And these look a little bit like fireman's hat. They look a little bit like fireman's hats there. And then there's ST depression here. Doesn't make any sense. Why would you have ST depression? Why would you have fireman's hats? And why would you have this funky, weird thing going on here? So there's got to be a reason. What's this right here? Do you see what that might be? Where my pointer is? What's that?
I see it, but I have no clue.
Okay. What happens when people have, let's go back to.
Is it from like a pacemaker?
Ah, good. Let's go back to this guy. If you get this guy and you give him a little bit of atropine, right? And he doesn't get any better. And then he starts to Brady down even more. What's the treatment? What are you going to throw on this guy? If he's symptomatic bradycardia. Think of your ACLS algorithm.
As far as like electricity, you're going to pace them.
Yeah, what are you going to do? This guy here has got third-degree heart block. We already said that. Now he's got chest pain and his blood pressure is starting to drop. Is he stable or unstable?
Unstable.
He's unstable. So we've got symptomatic bradycardia that's unstable. And what do we do with symptomatic bradycardia that's unstable?
So you
said the answer already. I heard you say it before.
You would pace him.
Yeah, pace him. And that's what that was. Sorry, third-degree heart block. Here we go. Hold on. There it is. Okay, so we pace him. Okay, here's the next one. Here's another one. Who's next?
Dang Tran, I think it's you. I don't think Dang has the ability to talk, so he'll have to type. All right, Dang.
I'm going to talk. We just got this guy. What do we see, normal or abnormal?
Dang says ventricular pacing. He says abnormal, but it's a ventricular pacemaker.
Yeah, there you go. Spike, 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 spike. And they look like rabbit ears. Is this a bundle branch block? Oh, but wait a minute. There's a spike there and spike there. Here's a trick question, but it's true. On some of your newer models, you're going to follow your pacer spike gets lost in some of your 2s and your 3s, and you may not see it until you look at another lead. So you got to sometimes switch between a 12 lead and your 2 lead and go back and forth, and there's a paced rhythm. Very good. All right, sometimes they're not noticeable, and you are unable to diagnose any acute injury pattern if somebody has a pacemaker. Now, you might have that third-degree heart block guy that you put the pacer on, or you might show up with somebody who already has an EKG on. Now, remember when we talked about trauma, we did A, B, C, D, E, and E stood for expose. I had a paramedic recently who had an EKG that was similar like this. He called the heart 1, but he didn't palpate the chest. If he did, he would have felt this huge egg in the patient's left upper chest that was a pacemaker. So keep that in mind. All right. Who's up next?
That would be John.
All right. John. Somebody.
John has to type too.
Okay, good. For normal or abnormal, John?
He says abnormal.
Good. So let's look where. 1, AVL, V5, and V6. Normal or abnormal?
Normal, he said.
Good. That's good. So we've got abnormal in the lateral. We're going to go to 2, 3 in AVF. And keep in mind that this right here in 2 looks a little bit abnormal, but it's only 1 beat, and this one looks pretty good. So I'm going to tell you ahead of time that this is a normal one. I know your eye was going to look at that. So 2, 3, and AVF looks pretty normal. All right. So lateral, now let's go to V1, V2, V3, and V4.
He says, I want a 15 lead again, and he sees anterior septal depression.
Okay, so here's the answer, all right? Here's a box. This is your flip test. What does that look like? Looks like a fireman's hat, right? So he wanted the 15 lead, and he was correct, because if you take this piece of paper, Dubin's will tell you to take the EKG and put it in a mirror and look at it. Who carries a mirror? Nobody. But if you hold this EKG up to the light and turn it backwards, you're going to get this view. So watch me. See, it's upside down and backwards, upside down and backwards, upside down and backwards. What does that look like? That looks like a fireman's hat. So Jess was completely right. He wanted a 12 lead or 15 lead EKG because he recognized deep ST depression in the septal area and in the anterior area, which means it's an inferior MI. All right, that's the answer, inferior MI. Okay, and this is our last one. This is an actual EKG tracing from one of our paramedics here. Who's up next?
Jesse, do you want to try it one more time?
Yeah, I'll try it.
Okay, normal or abnormal?
Say abnormal.
Good. So let's look at our regions and find out where. 1, AVL, V5, and V6. What do you see here?
Depression.
And there?
Depression.
Good. Here and here, this one doesn't look too bad, but I see a little bit of slurring, right?
Yeah.
So if I see a lateral depression, my eye should next go to here, 2, 3, and AVF.
Yeah.
And there's my elevation, right?
Yeah. Yeah.
So I've got lateral reciprocal changes with an acute inferior ST elevation. And then I see here some ST depression. So the reveal is going to be the EKG is acute MI suspected. This is what your machine's going to say to you. It's going to say some left atrial enlargement. Why does it say that? Because here's some biphasic P waves. And then it's going to see ST elevation, consider inferior injury or acute infarct. So you got somebody who's got this EKG and these changes. Are you going to wake up the cardiologist at 3 in the morning?
Yes.
All right, good job. All right, so now what? Now what we do is we call the cardiologist, we wake him, we get him out of bed, because he makes a whole lot more money than all of us, and he can see what's going on. So that's everything, guys. That's everything I got on ST elevation, MI. And we spent a little bit more time than we should have. So that's your Christmas present is, well, your Christmas present is you got to study. All right. Questions. I'm going to minimize this, and I'll try and take some questions.
I think most of you did very well because most of you haven't even been completely through the EKG qualifying exam yet. Right. So only a couple of them have been all the way down to the end, and I think they did really well. How do you feel like?
I think everyone did great, and don't worry about those little changes. And I put you on the hot seat because that's what your job is going to be, going on the hot seat.
Dr. Dangtran asks about the difference between an idioventricular rhythm versus left bundle branch block.
Oh boy, that's weeds, weeds, weeds. We're not going to the weeds. But an idioventricular rhythm and a bundle branch block is very subtle, and it's an escape rhythm, and you know, an idioventricular rhythm. I think in today's lecture, I'm going to avoid that question because there's too much other stuff I'd have to bring in. But just keep in mind that you're going to see, as you watch your QRS complex and electrically what's going on with the heart, you have to know what comes next. AV node, sinoatrial node, bundle of His, and where is the problem? And an escape rhythm is with a bundle branch block, the heart says, you better beat or we're going to die. And that's the best way I can explain it.
Dr. Eschelbach, Jeff wants to know, he says, pericarditis with all the ST elevation across the board. You mentioned giving nitroglycerin. Would you expect to see improvements with the elevation?
Oh, okay. What I mean, we didn't show a let me think. I don't think we showed a pericarditis EKG today. If you suspect pericarditis and you give nitroglycerin, you're not going to find much of a change. So I may have misspoken. When you have pericarditis, it's kind of like having a heart attack all over your heart. You've got diffuse ST elevation. You've got regions lateral, inferior, septal, anterior, and lateral changes all over, and it looks like the whole, you see ST elevation in the whole heart. That's really not going to be helped by anything other than just time. If you give nitroglycerin, it's not really going to make any changes in the EKG.
John mentions a very good point about briefly mentioning the importance of at least doing a V4R lead if you're suspecting an inferior MI. If you can't do a full 15 lead,
right?
The importance of V4R.
You can take your 3 leads, your last 3 leads, and put them on the side of the chest and repeat the EKG, and you're essentially getting a 15 lead EKG. Most of us don't have 15 lead EKGs, So what you do is you take V4, V5, V6 off, and you put them in the next 3 spaces, 7, 8, and 9, repeat the EKG, and you'll see ST elevation. That will help confirm it. But that's a little bit more of the weeds that we're talking about. That's for the next time. All right. Any other questions?
Well, Don was saying he was talking more, I guess I misworded. He was talking about the V4R, you know, importance in right ventricular MI. When you see the inferior MI and you're looking for right ventricular involvement, you know, that basically at least placing the V4R lead and you notice the change of V4R, it's, I believe that the stats are 97% positive for right ventricular involvement if you have the STA second elevation in V4R.
Yes, got it.
Dang Tram wants to know if pericarditis leads to pericardial tamponade.
Huh. The answer is a definite maybe. No. Pericardial tamponade happens when pericardial tamponade happens when there's a little bit of a rupture of one of the vessels where blood gets between the heart and the pericardial space. Pericarditis happens when the covering of the heart, the pericardium becomes inflamed, and electrically it looks like the entire heart is sick. So it's possible that you could have both, but they're not synonymous. The treatment for pericarditis is to essentially put the person on some aspirin and watch them. The treatment for pericardial tamponade is to get that blood out of there so the heart doesn't, stop beating. You're going to see pericardial tamponade at the end of your PEA algorithm. That's when you're going to suspect it. When you get to PEA, it's one of those things that you have to worry about when you're not getting any further. So I know that's kind of a roundabout way, but they're two distinct entities.
Dang says, sorry, I meant can pericarditis present Beck's triad like tamponade?
Oh, no. Beck's triad, no. They really don't have the same thing. Typically, pericarditis is most often a young person, sometimes a male, who is a few days after a upper respiratory tract infection, and it's usually a viral illness, and they are not your typical person who presents with heart symptoms. They usually have no heart disease by history, but they have a past medical history of some type of a cold, upper respiratory tract infection, something like that, that gave them an inflammation of their heart. It's usually a virus. The Beck's triad is specifically positive where you've got jugular venous distension and all that. That's pericardial tamponade. So they are two different syndromes and two different signs and symptoms. And that's pretty hard for you guys to diagnose. It's hard enough for me to figure it out in the ER. I don't expect you guys to figure it out. But what I do expect you to figure out is if you see ST elevation MI and it looks like it's all over the heart, then you think that doesn't make sense to me. You can't have a heart attack in every single vessel all at once. There you go.
They're all saying thank you for the help, Dr. Eschelbach. This was a great lecture tonight.
Great. All right, we went over. Sorry about that, but Merry Christmas.
No, I think that they're happy for it because this is one of the areas they have to pass in a bar called our EKG qualifying exam, and this is very helpful. And I'll be posting this also for the other paramedic students to be able to view.
Very good.
All right, Merry Christmas to all of you. Merry Christmas, Dr. Eschelbach, and when you get with me some more dates, I'd be grateful.
All right, will do. Thank you.
Thank you all. Good night.
Good night.
Getting coverage on the health insurance marketplace means you can worry less, especially when you need care. There is knowing I'm covered. Sign up by December 15th for coverage starting January 1st. Choose a health plan and take control of your health. The health insurance marketplace open enrollment ends